Good morning, everyone. I'd like to welcome you to the symposium on recent glaucoma trials, impact on management. And today we were supposed to have 7 speakers, but we have 6. So we have a little bit more time for each speaker because the third speaker, Dr. Song, is unable to come here. So we'll kick off the symposium by inviting the first speaker, Dr. Lingam Vijaya from Chennai, India, and she'll be speaking on EAGLE, what should we adopt and ignore? Thank you very much, Jaya.
Microscope is not.
No sound.
Yeah, the microphone is not working.
Okay.
Sorry. Good morning. The first topic that is allocated to me is EAGLE study. What should we adopt and ignore? Can you forward one slide? If you look at the literature, there are 3 publications from the EAGLE study. The first one was published, that is the methodology. And this is the most important paper that has given the outcomes of the study. And they also looked at the predictors of long-term IOP control and looked at the possible ways you can predict the outcomes. And if you, as a clinician, if you look at the EAGLE study, and the 3 questions that comes to our minds are, does it improve disease control in terms of the angle and angle progression, in terms of the IOP control, in terms of the disc and visual field progression? So with this background in mind, let's look at the study in a little bit so that will help us to understand these questions what we have today. The primary outcomes of the study happens to be quality of life and vision and intraocular pressure control, stability of the disease and safety of the intervention. It was, duration was 3 years after the randomization. And study groups, as you all know, early lens extraction surgery, that is clear lens extraction, compared to the standard care, usually laser iridotomy, followed by a sequence of medical therapy and glaucoma surgery. And the study centers, if you look at it closely, it is one from UK, the rest is mainly from Asia and Australia. And study subjects has to be more than 50 years of age, newly diagnosed PSC with IOP equal to or more than 30 millimeters, or PSCG, that is reproducible glaucomatous visual field defects or disc changes with IOP more than 21 on at least 1 occasion. And PSC was defined as iridotrabecular contact, either opposition or cynical, for more than 180 degrees on gonioscopy. And what was the difference of the study they were looking at to measure? Those randomized to early lens extraction will have, that was the hypothesis, a higher quality of life questionnaire score, the mean difference of 0.05, lower IOP, again note this, mean difference of 1.75, a 15% lower glaucoma surgery rate. And when they looked at the results, both the quality of the life and IOP control, they found to be better in the clear lens extraction group, which was statistically significant. And they concluded, our results indicate that clear lens extraction should be considered the initial treatment for primary angle closure glaucoma and primary angle closure with increased intraocular pressure. And if you relook at it, the primary outcomes they have looked at, it's the quality of the life. And if you look at the baseline characteristics between the clear lens extraction and EAC-PA, and the refractive error was little more in the clear lens extraction in comparison to the EAC-PA. Was the difference in refractive error responsible for the improved quality of the life? Once the lens is out, when the patient becomes pseudophakic and possibly quite happy without the hyperopic glasses. Was it responsible for it is a question that we should ask ourselves. And the difference of 0.052, what is the relevance of the 5% difference in quality of life? We have to ask ourselves before advising a clear lens extraction for this group of patients. And if you look at the primary outcome, what they have reported in terms of the intraocular pressure, yes, there was a difference of 1.18 millimeters between the clear lens and the standard care. And if you recollect the study hypothesis, they proposed the lower IOP, the mean difference of 1.75 millimeter was what was expected to have a meaningful outcome between the two groups. Did not meet the minimum difference they thought would be clinically significant at the beginning of the studies, because they got only a difference of 1.18, it's not 1.78. So the difference is 1 millimeter difference, even 0.75 what we are looking at, it makes a difference. So what about the angle? Because that is very important if you are looking at the progression of the disease either with the PSE or PSEG. And if you look at the gonioscopy data, the definition without indentation, they found 300-degree closure in clear lens, whereas LPA it is 360. Cynical around 90 degrees with the clear lens and 90 equal in the LPA group. What is important to be remembered is missing data. A study which is addressing angle closure outcomes, having this amount of missing data with the gonioscopy is something which is not acceptable, and it is almost cynical closure information is absent in 247. And if you look at the final visit, again there is a significant amount of the missing data even at the 36 months, both with the angle closure and information about the cynical closure. And did clear lens extraction improve disease control? Yes, there is a difference, statistically difference between the two groups, but the difference is not that amount. We don't have any additional information as far as the angle is concerned. Intraocular pressure difference is very minimal. There was no significant difference in change between the groups in terms of the visual fields. As a clinician, I like to look at the complications they have reported with the clear lens extraction. They claim that it is on par with the cataract extraction complication. But is it worth to subject an individual with a clear lens for this, even though it is a small percentage, to expose him to this complication rate is something we have to question ourselves. And coming to the long-term predictors, which was published much later based upon this 3-year data, among patients with PSC disease, they found that those with the initial clear lens extraction were 10 times more likely to maintain good drop-free intraocular pressure control over 3 years versus LPA. They found Chinese ethnicity, lower preoperative IOP, not using glaucoma drops, and no glaucomatous changes at the baseline factors were associated with the free drop postoperative IOP control. The question I have here is, when so much of angle data on the gonioscopy is not available, we don't know whether the group of subjects who really got benefited were having just a positional closure. With the lens removal, they all got benefited because none of them were on any drops, none of them were having very high intraocular pressure, just the lens extraction has helped. So unless you have sufficient information on the gonioscopy, I'm not sure whether we can claim that the clear lens extraction is going to control the long-term intraocular pressure. The cataract removal, the lens removal per se would have caused the drop in the intraocular pressure. So what is the caution we have to take it in mind? I know it is a big study, so remember removal of clear lens is not equal to cataract removal. All the clear lenses were operated by a glaucoma specialist who are used to doing the surgeries in such a situation. In spite of that, they had complications. One randomized study cannot be extrapolated to the whole of the primary angle closure disease spectrum. PSEG they had was very mild damage. We cannot apply it to the advanced cases till we gather sufficient data offering cataract surgery for significant cataract. If patient is having a significant cataract, offering the cataract extraction is ideal. Please offer laser iridotomy for eyes with clear lens. Did EAGLE study change my clinical practice? Exact in verbatim, it's not. So we have to keep all the possible things what I have discussed and consider doing the laser iridotomy for the clear lens if it is indicated, offer cataract extraction if there is presence of cataract in those eyes. Thank you very much.
Thank you. Are there any questions from the audience? I think we have, because we have one speaker less, we have time. Anyone? Dr. Vijaya, do you think that the...
I think there is one, Trupti.
Oh, yeah. Sorry.
Thank you, ma'am, for the excellent talk. My question is regarding what about if the patient has high lens fault? And do you recommend any cutoff to consider for the high lens fault, to consider lens extraction, particularly if we are planning TRAB also?
I think the EAGLE study is not addressing that aspect,
yes,
but if we are talking about the primary angle closure glaucoma in advanced stage that needs the trabeculectomy?
Yes, ma'am. Especially those who have a very narrow angle. So
That
there
is
a lens
again,
fault, because
again.
then the lens is clear. So then again that dilemma comes whether to touch that lens or not.
Yeah, and high lens vault is one of the predictors for the possible complications following the trabeculectomy. There are situations where one has considered removal of the lens in such situations. It's not a general rule for the clear lens extraction for that.
Yeah, I think the lens vault is very high, and although the vision may be good, it's an indication to remove it because that's probably the main anatomical risk factor with a big lens vault. Yeah. But I think, it's very rare that there are very clear, huge lens vault and 6/6 vision and I don't think it's going to be, it's probably have some degree of cataract usually.
Thank you, sir.
Dr. Vijay, in India, what is the current recommendation in terms of clear lens extraction? Is there like a GSI guidelines?
Yeah, I think part of my talk reflects the GSI guidelines. I think we do consider the lens extraction in presence of the any lenticular changes. And as you correctly have mentioned that if the lens vault is very high and it is causing problem, that is the only exception we will consider for the lens extraction. Thank you very much.
So it's my pleasure to invite next Professor Tin Ong from Singapore National Eye Centre, who's going to present Management of PACS, Lessons from ZAP and Analyst Trials.
Thank you. Good morning, everyone. I'd like to now move on to management of angle closure suspects, and this is from data from Singapore and China. I have no disclosures. I come from Singapore and from the Singapore National Eye Centre. So we know that angle closure glaucoma is an important form of glaucoma in Asia, and there are several stages of the disease. The earliest stage is that of angle closure suspects or narrow angles, people who have anatomically narrow angles but do not have high intraocular pressure, peripheral anti-syringe, or optic nerve damage. We also know that the prevalence of angle closure glaucoma is about between 1 to 2% in many Asian populations, but as many as 5 to 8% of the general population have PACS or narrow angles. So this data alone, you will conclude that most PACS will not progress to PACG. Let me give you an example of a 59-year-old lady with hyperopia of +2, 6/6 vision in both eyes, shallow anterior chamber, and early cataract. She has normal intraocular pressure, normal disc and visual fields, and showing appositional closure in 3 to 4 quadrants. And this is the anterior segment OCT of this patient. So this patient is a PACS and she has no symptoms with 6/6 vision. So how would you manage her? I think most people would either think of doing a laser PI in both eyes or observation. Of course, some people will even do a bilateral phaco, but remember, this patient has very minimal cataract. Now, if you elect for observation, many ophthalmologists, particularly in private practice, worry that they may be sued if the patient comes back with acute angle closure, or will still come back with severe angle closure, chronic angle closure glaucoma. We know that laser iridotomy can prevent pupil block and prevent acute attacks. However, there are also some adverse effects of laser iridotomy, including visual symptoms and corneal damage. So how do we manage people like this who have asymptomatic narrow angles and good vision? So how do you counsel the patient, and what do you offer in terms of treatment, and discuss the risk versus benefit? So this was the background of doing these trials in China and Singapore. Actually, they started at the same time, but the Chinese trial was completed much faster, and so they published first. So in this trial in China called the ZAP trial, it stands for the Zhongshan Angle Closure Prevention Trial, because it was conducted by the Zhongshan Ophthalmic Center in Guangzhou in China. In the ZAP trial, almost 900 patients with bilateral narrow angles or PACS were randomized to LPI in one eye and observation in the other eye, and followed up for 6 years. And the primary outcome measure was the incidence of PAC, defined as more than 24 millimeters of mercury on 2 occasions, or the development of peripheral anterior synechiae, or an acute episode of angle closure. And the mean age of the participants was almost 60 years of age, 80% were females, and most of the iridotomies were placed superiorly. The follow-up was pretty good. More than 75% completed 6 years. And the overall results in terms of the ZAP trial showed that about 4.9 per 1,000 eye years in the laser group developed primary angle closure, compared to 7.97 in the control group. And this shows you that it was almost double the rate of progression in the untreated patients compared to those who were treated with laser iridotomy. In terms of raw numbers, you would say that 2% progressed versus 4% in the observation group. So this is double. And this overall rate of progression was very low and much less than what was expected when the trial was planned. And although the hazard ratio showed a 50% reduction, overall the rate of progression was very low. The laser iridotomy was safe with no long-term adverse events, and the majority of cases to reach endpoints was PAC, mostly developed PAS, and very few people developed glaucoma. So certainly the ZAP trial recommendation was that the risk of progression in PACS was quite low, even without iridotomy. And certainly on a national level in China, they would not recommend community-based screening for angle closure suspects followed by laser iridotomy. In terms of the 14-year follow-up, the results were also showed an increased amount of progression, almost 12% in the control group versus almost 4% in the laser iridotomy group. So overall, still quite a low risk of progression. You would say over 14 years, less than 1% per year progressed. So the ZAP trial, of course, were people with Chinese origin, and so they may not be applicable to other populations. Most of the patients were younger in terms of age, and they didn't have much cataract, but that was intentional because, of course, if you have cataract, you can just remove the cataract. And patients were recruited from a community setting in Guangzhou in China. What about the Singapore analyst trial? We had a similar study design of laser PI in one eye and no treatment in the other eye, but ours was a 5-year follow-up, and the outcome measures were also similar. In the analyst trial, we had 480 patients randomized. Again, majority were Chinese, and there were more women than men. And overall, you could see that all 480 patients were included in the intent to treat analysis. And we had a very good follow-up of almost 90%. In terms of the pre-op factors, they were similar in terms of all the baseline factors. And overall, the progression rate was 11.65 in the LPI eye versus 21.84 per 1,000 eye years in the control eye. So it was much higher than compared to the ZAP trial. And the overall number to treat was 22, and the population at triple risk was 38%. You can see here, in terms of the progression rates, they were all quite occurred over time. It didn't happen really late. You can see the progression rate increased over time. And so overall, in the analyst trial, about 9% progressed if you were untreated versus 5%. So it was much higher than the ZAP trial, but still low overall. So overall, about maybe 2% per year progressed in the observation group. And there were mostly patients developed primary angle closure. 3 cases had acute angle closure, and very few cases of angle closure glaucoma developed. So again, the trial progression rates was much lower than what we expected, but certainly higher than Guangzhou. And you can show you that the majority of endpoints reached was primary angle closure. So the strengths of both the ZAP and the Singapore trials were they were randomized control trials using an internal control of the fellow eye. They had both large sample sizes with good follow-up and a very efficient data monitoring system. So overall, these trials show the low risk of progression for PACS, at least for 5 to 6 years, and raises the question of whether we are overtreating PACS with laser iridotomy. So right now in Singapore, we do discuss with the patients with PACS the option of laser versus observation, and we do quote the trial data, so we say up to 10% progress over 5 years versus 5% if you were treated by laser iridotomy. We explain the risk of both options and let the patient decide. Now you can see in the picture on the right is a picture that we see in Singapore in many bus stops. It says low crime does not mean no crime. And this is a very confusing poster if you're not Singaporean. But basically it shows you that in Singapore, there's very low crime and people are very complacent. And so you're warning the public that low crime does not mean no crime. So don't leave your telephone, for example, when you go to a food court. People in Singapore will leave their telephone on the seat when they go buy their food. And so because people know that they will not be stolen. So anyway, the analogy here is that I would say for angle closure glaucoma, PACS, low risk does not mean no risk. Yeah. So if you have a patient with angle closure suspect, you should discuss the risk because there are some risks of leaving the eye untreated. Certainly for patients who are older with cataract, just offer a phacoemulsification and you don't need to do laser iridotomy. We know that lens extraction will remove the pupil block. So who among PACS people should go for LPI? Certainly, if you have a fellow eye of primary angle closure or angle closure glaucoma or acute angle closure, should certainly go for LPI. People who are symptomatic, perhaps they have intermittent attacks. Patients who require regular pupil dilation, like for example, they're diabetics or they have AMD. People who have poor access who may not return. Family history is a question mark. Maybe they have a strong family history of angle closure glaucoma. I would certainly think about doing a laser iridotomy. And they could see other population or population-specific factors in your population. So in summary, I've given you an overall data of the ZAP and analyst trials, 2 large Asian trials which showed low risk of progression of PACS and certainly gives you the option of observation of these patients. You should discuss the risk of observation versus laser iridotomy with your patients, and if in doubt, perhaps you can offer a laser iridotomy. Those with cataract should undergo phacoemulsification. Remember, low crime does not mean no crime, so low risk does not mean no risk. I'd like to acknowledge particularly funding from the Singapore National Medical Research Council, and also all my collaborators and also fellows who worked on this trial over the 8-year period. And here's the acknowledgement of the Singapore our glaucoma research team. In SNEC, we do offer fellowship programs, and we offer fellowships, paid fellowships for all different specialties. So if your residents are interested, please ask them to apply. And I'd like to welcome you to Singapore for the Asia Pacific Glaucoma Congress and in conjunction with the SNEC 35th anniversary next year in July. Thank you for your attention.
Thank you, Professor Ong. Any question from the audience for Professor Ong?
Tony Homer from Vienna, Austria. Thank you very much for your nice, great presentation. But you know the other advertising which says, no risk, no fun. But that's of course not with this thing. What I want to point out is actually that the average age, at least in Europe, when you diagnose glaucoma, and there is not too much 1970s, where he was retrospectively analyzing eyes that had gotten, because of angle closure, the iridotomy in those days, and compared to where the fellow eye was not treated. And it was shown that after 10 years, 30% of the patients came with a visual field defect. And this was before computer perimetry.
So 30% of the untreated eye? And what about the treated eye?
Very low risk. No, this was more or less solved, but it was, the aim of this publication was to show that iridotomy, prophylactic iridotomy in the fellow eye makes sense if you had angle closure in the first eye.
Yeah, certainly I think maybe these patients had already had PAC or PACG at the beginning, and so the iridotomy had a difference. But of course, PACS people were at the early stages before they have any PAC or PACG for these trials. Yeah.
Question team is not with PACS but with PACG. So would you recommend an iridotomy for a PACG patient given the fact that if he has an iris atrophy or some amount of atrophy of the iris, would an iridotomy work in such patients?
I think if they have a patient iris atrophy from perhaps an acute attack before, they probably have limited effect, but I would certainly do it in the fellow eye of these patients. Yeah.
Yeah, but if it is a bilateral PACG with some amount of specific atrophy because of chronic subacute attacks and all that, would you advise such patients in iridotomy?
I think you'll have to look at the severity of the cataract. Often nowadays we go for earlier cataract surgery, and so if there was some cataract, I would do the cataract instead of doing an iridotomy.
If you decide not to do the LPA, if they need a dilated examination, you don't dilate at all, or you do dilatation with any precautions?
In Singapore, we just dilate them. Yeah. So it's very low risk of acute attack after dilation. So we had a study where we looked at 10,000 diabetics who went for routine dilation without any angle check. And these include people, I'm sure, who have PACS, but the acute attack rate was something like 1 in 10,000. Yeah, so.
Any specific drug you avoid or use, or any in terms of the Medriatic, what you use?
Tropicabine.
Yeah.
Thank you.
Thank you very much. So our next presenter is Yun-Hei Song, who's going to be a pre-recording speaker because he's not here.
Okay.
Oh, all right. So we don't have it all.
No.
Okay.
That's it.
Do you want to present this one? Okay, so the next presenter is
That's it.
Arthur Sitt from the United States, who's going to present on what we have learned from trabecular mixed trials.
Thank you very much. It's a pleasure to be here. So my talk will be a little bit different. First of all, my disclosures, none of which are relevant. Today, I'm not going to try to give you my opinion on trabecular MIGS procedures. Instead, I'm going to talk about an ophthalmic technology assessment from the American Academy of Ophthalmology, which looked at trabecular procedures combined with cataract surgery for open-angle glaucoma. And this is work from a panel, actually led by Grace Richter, and I was privileged to be part of that panel. So what are the AAO ophthalmic technology assessments? So these are documents that the American Academy of Ophthalmology creates to evaluate new and existing procedures, drugs, diagnostic and screening tests. And the goal of an OTA is to review their available research for clinical efficacy, effectiveness, and safety. For MIGS, the goal of this particular OTA was to review the current published literature on trabecular procedures combined with cataract surgery in adult patients with open-angle glaucoma, and specifically was to evaluate FDA-approved trabecular procedures with and without stent implants, including iStent, Hydrus, excisional goniotomies, including trabectome, as well as the Cahook dual blade, and trabeculotomy with gonioscopy-assisted transluminal trabeculotomy, or GAT, and OMNI-assisted trabeculotomy and canaloplasty. So the specific assessment questions were first, do trabecular procedures in open-angle glaucoma patients undergoing cataract surgery provide sustained IOP reduction or reduced medication burden beyond what would be expected from cataract surgery alone? 2, do trabecular procedures compare with one another in terms of efficacy and safety, and what are the advantages or disadvantages of each procedure? And then 3, are certain patients who may benefit from one procedure over another? So the evidence started with comprehensive reviews in PubMed studies or limited to English studies or studies that were published in English conducted up until February 2021, and then a second review was performed in April of 2023 with, as you can see, pretty comprehensive search terms. 279 abstracts were pulled out based on those searches, and then 20 articles were selected that met the inclusion criteria and were reviewed in full text. And those inclusion criteria were studies where the primary objective was to evaluate outcomes or complications from trabecular procedures combined with cataract surgery in adult patients with OAG. It had to be original research and had to have at least 6 months of follow-up. And then the evidence in each of these studies was assessed based on the Oxford Center for Evidence-Based Medicine scale. Level 1, 2, and 3 were level 1 were well-designed and well-conducted randomized clinical trials, and then level 2 were well-designed case controls and cohort studies and poorly randomized studies, and then level 3 were case series, case control studies, and historically controlled studies. So of all of the articles that were pulled out and reviewed, 20 met the inclusion criteria, and of those 20, 10 had level 1 evidence. And only studies with level 1 evidence were included. And the effect of that was any studies that looked at trabectome or ab-internal canaloplasty or GAT ended up being eliminated. And then the goal was to focus on mean IOP reduction and mean medication reduction when that was relevant. A couple of notes about the published studies. So all of them were industry-sponsored, and then all the patients had hypertensive glaucoma, mild to moderate stage. They're on medications, and they're undergoing concurrent cataract surgery. Some studies included only POAG, while others included secondary glaucomas, including exfoliation and pigmentary. So what did these studies find? So first of all, in terms of iStent, there were 2 large randomized clinical trials evaluating iStent efficacy. The first, for the Gen 1 iStent, did not wash out their patients prior to assessment of ILP efficacy, and that complicated a lot of their results. So at year 1, there was no difference in ILP reduction, although there was a favorable effect in terms of medication reduction. By year 2, however, they do start to separate a little bit. So you still have a reduction in IOP, relatively small, 1.5 millimeters of mercury, whereas the effect in cataract surgery alone essentially has disappeared. And again, you maintain a small improvement in terms of medication reduction. For the second generation iStent, the iStent Inject, these were washed out patients, and at 2 years, there was a statistically significant benefit to having iStent plus cataract surgery versus cataract surgery alone in terms of IOP reduction. So 7 millimeters reduction versus 5.4 millimeters reduction. For Hydrus, there are also 2 main randomized clinical trials. The Hydrus 2 washed out their patients, and they found at year 1, IOP reduction was again slightly better with the Hydrus than with cataract extraction, a 36.9% reduction versus a 34.6% reduction. And then again, that also spread out a little bit as you get further away, so a larger difference at year 2. The Horizon trial was a similarly designed study at year 1, again showing a positive effect of Hydrus compared to cataract surgery alone, persisting to year 2. And then by year 5, much of the effect has been lost, although there still is a benefit in terms of reduction of medication reduction and possibly slower visual field progression. Now, for excisional goniotomy, were no pure RCTs looking at KDB alone, but there was a randomized controlled study comparing KDB and iStent, and what it found is that without washout, both KDB and iStent resulted in about an 11 to 15% reduction in IOP compared to cataract surgery alone, but there's no difference between the two devices. And then the medication reduction were also the same between the two devices. So how about comparing iStent to Hydrus? So there were no direct comparisons in terms of randomized clinical trials, but the 3 independent studies that did have similar designs, which allowed us to compare their efficacy. So the iStent Inject trial, the Hydrus 2, and the Horizon trial had similar study designs. And all 3 of them reported IOP reductions, which were actually pretty similar. So 28%, 28%, and 21%. So between 5.4 and 7.6 millimeters of mercury reduction. So the additional reduction over cataract surgery alone was very similar between all of these trials, with a little bit of a benefit towards the Hydrus devices over the iStent Inject. And then all 3 trials also reported similar reductions in terms of medication reduction over cataract surgery alone, with a 75% reduction for iStent Inject and an 80 and 77% for the Hydrus. So in terms of efficacy, to summarize, there's no clear benefit of adding one procedure over another. In terms of additional effect beyond cataract surgery, an additional 4 to 9% IOP reduction can be expected by one of these devices over cataract surgery. But remember, cataract surgery alone reduces IOP by about 21 to 28%. And so this additional effect really means that you can expect to eliminate, you can reduce IOP by 5.4 to 7.6 millimeters of mercury, or you can eliminate about 1 eye drop. So how about safety? So none of the studies report safety uniformly. Uveitis seemed to be a little bit more common with the Hydrus than the iStent Inject, but a pretty low rate. Hyphema, again, a little bit higher with Hydrus than the control group, and with KDB compared to iStent, but again, pretty low rate of hyphema. And then corneal edema did have a slightly higher rate of corneal edema versus the control group, but the statistical significance was not reported in their studies. And then in terms of secondary surgery, and low rates in both the treatment and control groups for both the iStent as well as the Hydrus. And there are no reports of secondary IOP lowering procedures in iStent versus KDB. In terms of endothelial cell loss, there was no statistically significant difference for either iStent or Hydrus. And then important to remember, there are some limitations of the data, even when we just look at the high-quality randomized controlled trials. And first of all, none of these studies looked at normal tension glaucoma. All of them looked at hypertensive patients, and so randomized controlled trials for NTG patients are clearly needed. And there is the risk of industry bias. All of these trials were industry-sponsored, usually registration trials. Nearly all of them had first or corresponding authors who had financial interests in the companies, and so there definitely is a need for future studies, randomized controlled trials that are not industry funded, to try to balance the literature. So in conclusion, trabecular procedures do seem to offer mild IOP reduction beyond cataract surgery alone in hypertensive open-angle glaucoma patients of moderate to mild stage. The IOP reduction is about 2 millimeters of mercury beyond cataract surgery alone, and that results in about a 0.4 reduction in number of medications at 2 years. The trabecular procedures alone can reduce the need for cataract surgery by about 1.8 to 2.5%, reduce the risk of secondary glaucoma surgeries beyond cataract surgery alone by about 1.8 to 2.5%. And then studies with visual fields as primary outcome are definitely needed. So based on the available data, though, there is no clear benefit of one procedure over another. So thank you very much, and hope to see everyone in Hawaii in a few months.
Thank you. Questions for Arthur? Tony?
Thank you very much for a really very nice presentation. this study, and in all these studies, it's defined that the success rate of 20% of IOP lowering. If we think now about medications, if you want to get a new medication on the market, the benchmark is the prostaglandin, or maybe the better proposition would be at least 25% of IOP lowering. Don't we have a too low a level of IOP lowering effect to define that it's a success? Because it's an invasive procedure, so you should expect actually even more efficacy to define it that it's a successful intervention.
I think that's a great point. You know, when do we actually use these devices, and what is the clinical benefit? And I think so for this OTA, that's why it focused on the use of the device concurrent with planned cataract surgery. And as you saw, there was a modest benefit. I think it would be a much more difficult argument if you were using these devices as standalone procedures.
And I think also the definition of 20% comes because they're not comparing to drops, they're comparing to these clinical trials like TVT, where they looked at 20% reduction in IOP for the out in terms of defining success, basically.
Any other questions? Okay, thank you so much, Arthur. We moved on to our next speaker, Dr. Anton Homer from Austria, and he'll be speaking on what we have learned from trials on normal tension glaucoma.
So good morning, ladies and gentlemen. I want to thank very much for inviting me here to give the talk. It is a great pleasure for me to be in this very interesting and fascinating country. For those of you who had not made any sightseeing, this is from the biggest mosque in India, and it's really very nice to see that. So my topic is about the trials in normal tension glaucoma. My financial disclosure is none, but the first thing is actually we have to be sure that it is normal tension glaucoma. I don't know how it's in India or in Asia. I can tell you in our country, for example, the misdiagnosis is very frequent. Gonioscopy is not performed frequently, and you can see it here in the United States, Canada, and South Korea. They didn't make sufficient evaluation of the angle, so how can you be sure that it's not maybe angle closure or something like that? The same is with the intraocular pressure measurement. We know that the intraocular pressure can fluctuate quite a lot in the normal 6 millimeters, and in the sick disease one, you have a fluctuation of 10, 15 or more, and maybe these IOP levels are not during your office hours, but in the night. Pachymetry, we know that there is no calculation of formula that you should need, but corneal thickness for sure is a relevant topic to consider. And then the position, of course, as well. When you measure the intraocular pressure, you should think about how is the condition and how is the pressure in the different positions. And then, of course, there are other optic neuropathies we have to consider, that they are maybe at the first aspect leading to the diagnosis of glaucoma, but there is another reason behind it. And of course, the visual field, which is a psychophysiological examination, depending very much on the mood of the patient. Is it really reliable? And the defect is only reliable if you have it confirmed at 2 consecutive visits. So we should make more visual fields as well to be sure. And then, of course, there can be other reasons why the pressure has been elevated in the past and produced the damage, but now maybe it's not anymore, like pigment dispersion, where you had steroid therapy, trauma, or other reasons. So is a normal tension glaucoma arbitrary? So I have to go, being European, to the EGS guidelines, the European Glaucoma Society, yes? And there it is clearly said that a substantial proportion of patients develop primary open-angle glaucoma at IOPs within the normal range. Primary open-angle glaucoma has been arbitrarily subdivided into high-pressure and normal pressure diseases. So glaucoma with low intraocular pressure levels may be more common in women with vascular dysregulation, migraine, and Raynaud, and we can have disc hemorrhages and paracentral scotomas. They are more common probably in the normal tension glaucoma. We have 2 main studies that deal with this topic, and it's the collaborative normal tension glaucoma study, which is now 27 years ago, and the early manifest glaucoma trial. And you are familiar with the first one, where they were looking on patients where they made intervention with treatment of medication, laser, or surgery, and the other group had no treatment at all. And the outcome was the progression of the disease. And there you could see then nicely that there were 230 patients eligible, but only those who exhibited a real confirmation of the visual field defect were randomized, and these were 140, so nearly 100 less. And a 30% intraocular pressure reduction from baseline was the treatment goal and was maintained in nearly 50% of the patients. But progression occurred despite of that in 12% of the treated patients and 35% of the controls, so 3 times more of the controls. But of course there is a significant part that did not progress, so 65% of untreated pressure patients had no progression over the years. So, but the beneficial effect of intraocular pressure lowering was found only after the data was censored for the effect of cataract formation on the visual field, because they found out that cataract formation has a significant impact on it. Yeah? And cataract surgery, cataract was more common in patients treated with surgery, and we know that surgery, glaucoma surgery, induces and stimulates cataract formation. And the EMGD study, the early manifest glaucoma trial, which was done in Sweden, yes, was treatment versus no treatment. And it's interesting, the primary outcome measurement was progression of the disease. Yeah? And it's an old study, it was from 1993 to 1997. And they had to have a substantial visual field deterioration or optic disc change. And when we looked then, 25% decrease from baseline, and the mean IOP at baseline was 20.6. So there have been quite a number of normal tension glaucoma patients included in this study. Yeah? But it was a reduction of the relative risk of progression of 50% over the time. And the important risk factors in this study were pseudoexfoliation, higher intraocular pressure, more baseline damage, higher age, disc hemorrhage, thinner cornea, and low pressure, low blood pressure in the normal tension glaucoma patients. And this is an interesting link, and we know that there is some relation for the general conditions to it. Untreated progression was slower in the normal tension glaucoma than in the high tension glaucoma eyes. And pseudoexfoliation, of course, has a very negative influence, and these eyes progressed much faster. The frequency of disc hemorrhages was higher with low intraocular pressure in women, especially, and with myopia, and it was not influenced by any treatment. And then there is this recent study from China, and where they were looking in Wenzhou about normal tension patients. It was a prospective untreated study of more than 2 years. Actually, the average observation was 70 months. And the functional progression was defined as a visual field deterioration or structural change in this. And the conclusion was that nearly 2/3 of the untreated Chinese patients with normal tension glaucoma progressed over an average of 70 months. Disc hemorrhage, female gender again, high pressure, shorter axial length, and lower blood pressure were significant predictors for the disease. So here you can see nicely, it is interesting that about 2/3 of the patients were female in this study, and the baseline IOP, it's just 1 millimeter of mercury, but statistically interesting, yes, and the history of disc hemorrhage is significant as well. And then when you look into this study after 2 years, and you look just on visual field progression, you do not see too much progression. The same is with the structural progression, it's not too much after 2 years. But if you look at the glaucoma progression and combine, then you see after 2 years yet a significant change. The limitation of this study is that it's a small sample size, only 84 eyes, and it's a mild stage of glaucoma, and they were not looking on family history, migraine, and others. Being in India, of course, you should mention a little bit about yoga. There is the recent study, effect of yoga on pressure, and there is this review, and they were looking controversial results. And you have, in these 3 studies, you see the lower 2 ones, they had an intraocular pressure far below 20, so there were quite a number of normal tension glaucoma patients seen in here. And in the discussion, then they say that the reduction of intraocular pressure following some specific positions of yoga, I'm not doing yoga, so I can't tell you anything personally, means that you can have a lowering of intraocular pressure, but there is an error as well. You can have a rapid increase after the beginning of the pressure. As a summary, they say that practicing yoga positions where you postpone your head down, these are the ones you should not recommend for your glaucoma patients. So what is the difference at the end of high pressure glaucoma to normal tension? The pressure level, of course, the visual field defects, they are looking different. The optic nerve head can look a little bit different. You have the images, and you have the risk factors from a general aspect. But similar is the target. The target is the intraocular pressure, and we know that we need the lower intraocular pressure. We know that ocular blood flow could be, to a certain extent, different in normal tension glaucoma compared to primary open-angle glaucoma, and the systemic conditions play a role. So what are the needs in normal tension glaucoma? It's very low target pressure. It's like in an advanced open-angle glaucoma. We should reduce them significantly. But there is not so much evidence about making more trabeculectomy, therapy of the blood flow, neuroprotection, citocholine, nicotinamide, or other things. So as a summary, normal tension glaucoma is to some extent different to high pressure glaucoma, but lowering the intraocular pressure is the only evidence-based approach we have. The lower the better, but we know that some progress anyway. Especially in these patients, I would use other options as well, especially if the patients are asking for that. With this, I want to come to the end from Gandhi, who said, do not listen to rumor, but if you do not believe it. I hope this doesn't fit to my presentation, and I thank you very much.
Thank you very much. Any questions from the floor for Dr. Hammer?
It's a very nice presentation, Anton. So I have a question. So do you do any other systemic workups for your NTG patients, such as 24-hour blood pressure?
In patients who progress, and I have a low pressure, then I make 24 hours blood pressure measurement, and I make carotid ultrasound. And I must tell you that out of, I don't know, let's say 1,000 patients, maybe 10, but got very soon afterwards, because of significant stenosis, they got a surgery. You can now discuss if it's worth it. You make 980 or something like that examinations where there is no surgery afterwards needed. But the few ones were very happy that they got the surgery at least. But it's a challenge, and I think you have to communicate with the patient, and if they're frightened, and sometimes I prescribe ginkgo, and we know the evidence for ginkgo is mediocre, but you want to do something, and the patient wants to have something, and if you don't offer them any option, they will maybe get lost or something like that.
We'd like to introduce the next speaker, Puma Chan from Hong Kong, China, who's going to talk about the ocular hypertension treatment study, an update, and the future.
Thank you very much. It's an honor to be here today. And so I would try to get through this quickly because there are actually quite a lot to get through. These are my financial disclosure. Now, basically, I will give you a brief outlines and backgrounds about what happens in the OAK studies, cost-effective analysis, quality of life, risk factors, calculations of the risk, and also visual field and the roles of imaging. Now, this is basically the OAKS in a nutshell. So it's a massive cohort with 20 years of follow-up. So in the first 5 years, it was a randomized control trial, treatment or no treatment. And it shows that after treatment, obviously you reduce the rate of having glaucoma by half. And they also identify important risk factors that was combined with the European glaucoma prevention studies, including the older age, high intraocular pressure, thin central corneal thickness, a large photocup ratio, and also high pattern standard deviation value, which I'm sure are quite familiar to most people here. Now, at 7.5 years, they start treating the patients without treatment, right? So everyone is treated, and it shows in the OAKS-2 and 13 years time of follow-up, it shows that the delayed treatment, effectively is delayed treatment, did not actually initiate the process of irreversible deteriorations in most patients, nor it render them to be less responsive to treatment. So you can delay it, you can observe the patient if you have to, and then you have the choice of treating or not treating the patients. And overall, 70% of the patients were treated in the 20 years time frame. And recently, they published the data and showed that the cumulative incidence of visual field loss in at least one eye is about 25%. So the rate is still quite low. All right, I have tried to summarize everything in the Asia Pacific Glaucoma Guideline. You can go and read it up. In the guideline, I also include the risk factors that is probably going to be related to OAKS, Some of them are related to OAK studies. Some of them are from other studies. Importantly, the OCT parameters are actually from patients' studies that involve glaucoma suspect. And so thin baseline RNFL perhaps indicates preparametric glaucoma and also abnormal classification of RNFL as well. So these are something that you might have to bear in mind. Now, there are certain key issues in ocular hypertension treatment studies, including it shows that it is not cost-effective to treat all patients with ocular hypertension, all right? There's a problem with risk assessments. Also, it's quite difficult to predict who will develop POAG, all right? And also visual field changes and the follow-up schedule is also an issue. How do we monitor these patients? And would imaging actually helps us? Imaging is developing a lot, and back in the OAK studies days, they don't really do much OCT. In fact, it wasn't such a fashion at the time. Now, if you look at cost-effective analysis show, definitely it's not cost-effective to treat everyone, all right? And if you look at the rate of glaucoma development carefully, in fact, to prevent one patient to develop glaucoma in 5 years' time, you're talking about a number needed to treat about 20. So it's actually not very cost effective. And we have to balance between quality of life and also prevention of glaucoma progressions, all right? We know that the drops would actually reduce the quality of life quite a bit for our patients, especially in the long term. And there's no general standard guideline showing telling us what to do. But then, generally speaking, there are many suggestions, and most of them would tell you that you can observe the low-risk group, but be very, very careful about the high-risk group. And importantly, for the pre-parametric POAG in the cohort, they realized that it did not report a lower quality of life. So, functionally, they're fine. And if you think about it, if you have drops for those patients who didn't even have preparametric glaucoma, but those with normal patients who might be embedded within the cohort, then you might be causing trouble. Ideally, you only want to treat the patients who will develop glaucoma, all right, and identify the faster progressor and treat them aggressively. You try to avoid medication side effect and also avoid redundant treatment, which is very difficult. This is something you don't want to give for your patient who doesn't really need the drops. In fact, for severe side effect of glaucoma medication, you're talking about a reduction of 10 decibel in mean deviation. So for patients who doesn't really need the drops, you're reducing the quality of life for that patient. And remember, patient with ocular hypertension with no visual field defect, they have perfect health utility. And so reducing them by 10% with the eye drop side effect, it might not be totally justified. You can estimate the risk with the risk scores as shown here. It includes the age, central corneal thickness, intraocular pressure, PSD value, and also the vertical this ratio. All right, so you can assess that. It give you a specific percentage of risk of having glaucoma in 5 years' time. Recently, the polygenic risk score is also getting very heated, very hot. PRS is already shown to enhance the predictive models in macular degeneration, diabetic retinopathy, and also POAG. Perhaps in the ocular hypertension patients, a high PRS has been shown to suggest a higher risk, independent risk factors for POAG development. All right, so this is something we might have to explore, but it's not commonly available in the clinic at the moment. Now, talk about visual field progressions. Most patients would have a slow progression rate in the cohort. However, if you look at it carefully, some of them get really sort of fast progressor, and they get worse despite being followed up in the clinical studies. You're talking about a 6-monthly follow-up, intensive follow-up for the last 20 years. So this is, and they still progress, all right? And the OAK study group suggests that the low-risk group, you can monitor them every 12 months. And for the moderate to high-risk group, you can monitor them for about every 6 months, all right? Study also shows certain risk factors for the fast progressor. They are some of the familiar risk factors you are probably quite familiar with, and they overlap with the normal tension glaucoma risk factors, in fact. Talk about the visual field pattern. We always have the assumption that the visual field progression start from the periphery, and now we know that they can start early in the central vision. In fact, it could up to 40% of the patients might have central visual loss in the very early stage of glaucoma development. So be very careful about that. The machine learning method might be able to allow us to predict who will develop early glaucoma or become a rapid progressor. But this is something that, again, is not universally available in the clinic. In reality, we have a busy clinic. We might just give that patients eye drops quite freely without asking about the side effect. In fact, many years ago, I tried to take off the medication for some of my patients. Out of the 107 eyes we deal with, only one patient had repeated visual field defect. And this is the patient. You can see that's an early defect, very subtle. In fact, this patient, even after taking off the medications, he turns out to be a patient with normal tension glaucoma instead of ocular hypertension, which was previously diagnosed. And we managed to stop a lot of medication, so that's a lot of cost saving. But be very careful when you're using the risk estimator, all right? You're making assumption that these are the most accurate variables that you can get from baseline, which is not really quite the case. And so measurement change, their variability, and so be very careful when you're using the risk estimator as a guideline for your treatment. In fact, if you change the photocoptic ratio, we try to do that with different measurements, including stereoscopic photograph, HRT, and OCT measurement, and we know they have disagreements, and that disagreement would actually tick all the way to your risk assessment as well. So don't get misled by the score. And it might not be universally applicable to all populations. So it's largely in UK shows that it doesn't really quite work very well in that population. We have to, but the overall re-estimated model was actually performed better. So you need some modification for the risk calculator. Even though it shows this good discrimination treatment for the treated group of the OAK studies. All right. And remember, in the OAK study, the minimum amount of Asians, I remember it was about 20 to 30 Asians. So, whether or not it really works for the Asian, we don't really quite know. Talking about taking off medication, I've been taking off medication for some of the low to moderate risk patients for 5 years. 4 eyes develop glaucoma, so that's quite a low rate. And in fact, imaging could play a role because if you look at these patients, all right, early signs already shown that there are some glaucoma, but it's not really quite in the definitions of the OAK studies. And so the trend-based, the GPA of the OCT already shows early changes followed by visual field defect. And PSD value was the only risk factors that would predict the progressions. Now we have trend-based analysis, which has been shown to be even better than GPA. We have the ROTA, which might allow us to have early detections of glaucoma. In fact, from the ocular hypertension cohort in our studies, 10% of the patients actually have found some early changes, despite the fact that they were judged to be normal. All right. Artificial intelligence, we're still quite early, but there are lots of potential in terms of diagnosis and also predicting who would get a faster progressor or detecting early POAG. Take-home message is that not everyone needs to be treated. We have to balance between quality of life and also preventing glaucoma. It's not as risky as you think, all right? So you might think about taking off some of the medication for some of the patients, unnecessary eye drops if they suffer from side effect. Role of AI is still unknown, but it's promising. So I hope that we see you again in the APO next year in Hong Kong, and thank you very much.
Thank you. Any questions from the audience? So, Pullman, if I could ask, has the OHTS changed your practice? So how do you decide if you have a patient in front of you? Not all of us have access to this kind of program you said in terms of determining who to treat or who not to treat, and definitely none of us use AI in clinic. So how do you decide who to treat with eye drops? How often do you follow up in the virtual clinic or doctor's clinic? How do you decide?
It's difficult. I think it's always important. It's the cliche. You discuss with your patients. All right. You tell them that this is perhaps the risk. This is the figures. And right now with these calculations, this is what they tell you. But be careful. This is only for reference. So do you want to be treated or not? And in fact, some patients who are worried but don't really quite want to do eye drops for their whole life, they might even think about SLT. And in the light trial, there are a significant number of ocular hypertension patients there. So that might be one thing that you might think about doing, but it's still a bit controversial. So you have to give the option to your patients before deciding what to do. But importantly, monitor your patient.
You have answered that partly, but I just want to know, in high-risk ocular hypertensive, is SLT your first choice beside or the drops, which usually you choose?
Sorry, can you repeat the question again, please?
Your high-risk ocular hypertensives, would SLT be your first choice or the drops? And any trials done comparing SLT head-to-head on medicines on these patients' ocular hypertension?
You mean for the high-risk patients?
Or otherwise, ocular hypertension whom you wish to treat, either would you prefer a SLT or the drop as a first line?
Right, would I prefer doing Zen or the drops? Would I prefer doing the drops or
The selective
SLT.
laser trabeculae
SLT or the drop?
vis-a-vis
For the high-risk one, given that they don't really have glaucoma, I might go for SLT, provided that the OCT imaging is very clean. All right, if there's obviously no signs suggestive of preparametric glaucoma, then I might go for SLT. In fact, even if there are, without a significant visual field defect, well, ocular hypertension, no visual field defect, I might still go for SLT. And the thing is, we also have to look at other factors. How high is the pressure? How often is the patient coming back? I mean, there are patients who you do SLT and they just run away, thinking that everything is sorted. All right, so I think it's very dynamic in terms of the decision.
Thank you. I think people are moving towards earlier SLT because of the light trial data, especially for OHTs.
Just one more question. If you had somebody was progressing on OCT, but the visual field was still clear, would you then prefer SLT or medication?
Yeah, good question. I'm not sure really, because remember in the OCT, even with the trend-based or the GPA, which GPA is more common, it's not commercially available. Now, even with the GPA, it's telling you that it's a significant, statistically significant RNFL progressive thinning. Whether or not that would translate to a clinical significance, we don't know. We just know that it's a risk factor that would predict visual field progression, but we are not sure whether, but in some of the studies that's shown by Chris Leung, they don't all develop visual field defect. So, whether or not we should be doing the treatment decision guided by the OCT, this is quite questionable. For me, I'm not entirely a fan of the light trial. I mean, it's a great studies, but we also have to be very, very aware of that. The light trial has a very intensive monitoring system. It's so intensive that it's impossible to be done in the clinic. All right, and also they adjust the intraocular pressure target in terms of what they found in that intensive monitoring. So we have to be practical as well in terms of how reliant we are on the light trial results. It's a great study, but it's very difficult to follow in the clinic.
Okay, thank you very much, Poman.
Thank you.
The last speaker couldn't come to India because of visa issues, but he has sent a recording.
Thank you, organizer, for inviting me here. My name is Franklin Lin. I come from Zhongshan Ophthalmic Center. I would like to share with you if effect of intraocular pressure reduction on progressive high myopia, a randomized controlled trial. I don't have a conflict of interest. Myopia is increasing worldwide. It is estimated that there will be 1 billion in 2050. It brings lots of visual impairment, including cataracts, retinal detachment, and glaucoma. Studies have confirmed that annual growth of axial length in HM adults, even 0.1 millimeter per year. Literature review shows intraocular pressure correlates with myopia. For example, more severe myopia was associated with greater odds of glaucoma changes in IOP influence axial length, and lowering IOP inhibited myopia progression in experimental models. We once hypothesized that the lowering IOP might help control HM progression by potential mechanisms, including reducing distending force, scleral remodeling, and increased choroidal perfusion. Previously, observational study had reported that the use of IOP lowering medication was significantly negatively associated with increased AL. And our results from a prospective observational study also confirmed that IOP lowering could control AL elongation in the HMI. Anti-glaucoma medication is a protective factor for AL elongation. Using anti-glaucoma medication reduced AL elongation by 7.5%. However, there is a lack of guidelines or consensus on the treatment. Hence, we have decided to launch an RCT project about lowering IOP to control the progress of high myopia. The purpose of the study is to test the hypothesis that IOP lowering medicine treatment reduces the AL growth in HMIs compared with the control group. The study is designed as open label, single center RCT. There are two groups, including intervention group and control group. The total follow-up duration is 12 months. The inclusion criteria indicate between 18 and 65 years diagnosed with HM, AL growth more than 0.05 mm in the past 6 months or more than 0.1 mm in the past 12 months. IOP is between 10 and 21 mm Hg. Primary outcome is progression rate of AL. The sample size is 152 cases. Since June 4, 2023, we have enrolled a total of 131 participants. Among them, 60 have completed 12 months of follow-up. When we included the 60 participants in the preliminary analysis, we found that after using the IOP lowering medication, the growth rate of IL in the intervention group was significantly slowing. Moreover, the rate of axial elongation in the intervention group was significantly slower than in the control group. Our preliminary result shows that lowering IOP can help control HM progression. Let's take a conclusion. HM is a major blinding disease. There are no established guidelines or consensus on the treatment of axial elongation in clinical practice. Lowering IOP might help control HM progression. The preliminary results of our RCT offer more evidence that lowering IOP decreases the growth rate of AL in HMIs. In comparison with the control group, lowering IOP slows the axial growth. We hope stronger evidence is provided when the RCT is completed. Thank you all the members' contribution from Glaucoma with HM study group. Thank you for our team.
Thank you. Very short talk. Okay. I think we now have some time for discussion for any of the speakers, if anybody has any questions. Yes, thank you.
I have a question to Anton Homer. Very nice presentation, and I agree that we lower the intraocular pressure in normal tangent glaucoma, but we sometimes face progression cases, even though we lower the pressure with medication. In that case, my question is, do you do surgery on normal tension glaucoma? The second question is, if you do, what kind of surgery do you prefer? Trabeculectomy with mitomycin C or MIGS or other surgeries?
Thank you very much for this interesting question. The thing is, it depends on the IOP level where the progression is. If this patient has an IOP level of, let's say, 10 to 12 millimeters of mercury, we are not so interested into trabeculectomy or any surgery. If the pressure is 17 or something like that, then we consider surgery, and if it's surgery, then it's trabeculectomy with mitomycin C, because actually our target would be a pressure of 8 to 10, something like that, would be ideal. And this is something what you, in my mind, you cannot reach it with any mix, but you can reach it probably or maybe with a trabeculectomy. But if you have a patient who progresses with a level of 10, then I don't see any sense for the surgery because you can only lose.
I have a question regarding MIGS, that we have access to KDB and iStent, and I'm doing that routinely. With iStent, I see a drop of around 20%. In your institutes, what is your protocol of selecting the MIGS device? Because we have deluge of so many. We have a hydrous use in India. So what has been your experience with iStent, hydrous and other devices, and what's your protocol of selecting any one of them in your patients?
So if I understand you correctly, which device do you use and how do you select them? Is that right? Okay. Maybe go to Arthur first.
Yeah, so I think in terms of which device to use, I think one of the things that was clear from the ophthalmic technology assessment is that it doesn't matter. Any of those trabecular devices will provide approximately the same IOP reduction and reduction in medication. So whichever one you're comfortable with or able to get, it doesn't matter. Me personally, I probably use the iStent most frequently. But that's a personal choice. I think any of the trabecular devices will be similar in terms of efficacy.
If I may add, I think the jury is still out because the fact that we don't have an antifibrotic we can use in the eye, a lot of these trabecular meshwork MIGS or even suprachoroidal MIGS, although they might work initially, we have evidence that, especially in high-risk group, they don't last for very long. So the jury is still out because we don't have actually any drugs we can use at the moment.
Pullman, in Chinese university?
Yes.
Which mix do you all use?
Well, I use the iStent. We don't have hydrous, and sometimes, well, for the angle closure, actually, a lot of the time, if you just do some GSL, it actually works fairly well. But usually for us, so the mix we do the iStent, and for the the platforming one, we have stent and also microshunt. And
what?
Sorry.
What was that?
Stent and microshunt. Stent and microshunt for the PreserFlow, for the platforming.
So both Zen and PreserFlow.
Yeah.
Yeah. In SNEC, we only use the iStent and the hydrous, and we have the PreserFlow. We don't use Zen anymore. Yeah. So those are the mix that we have. Tony?
I want to add to the previous question as well, because I've forgotten that we do not make any mix anymore because we think 1 millimeter of mercury IOP lowering for 1,000 euro is just too expensive. It makes no sense. But what we do are the MIPS, and we are definitely differentiating MIX and MIPS. MIPS are the ones with the bleb. That means this is the microshunt or the Xen. We personally, in Austria, I can speak for the others more or less as well, mainly use the microshunt, because it has the advantage that you can make afterwards something if the pressure is too low or too high. You can modulate it. With the mix, you cannot do anything. But of course, you have to consider that you can have complications with the microshunt as well. You can have hypotony, for example, as well. So it could be the same troubles you have with trabeculectomy, you can have it with the MIPS. But in some patients, MIPS maybe is a little bit safer, let's call it like that, than the trabeculectomy.
I think in terms of normal tension glaucoma, a lot of us, although there is no trials which shows this, would probably go for a trabeculectomy rather than a PreserFlow microshunt, because we do see that we can achieve lower IOP with trabeculectomy.
Yeah, I agree with you, yeah.
So Tony, I was interested in your comment saying that you won't do a TRAB in a normal tension glaucoma patient if their pressures are already 10 to 12. I'm curious because I would. The reason is that there's nothing better than a TRAB in terms of stabilizing the ILP, reducing the nocturnal elevation, reducing fluctuations. And I think that may be very helpful in a lot of these patients.
Yes, if it's the ideal world, yes. But we have, I mean, I have patients who have a pressure of 5 and they get no choroidals and nothing. And there are patients who have a pressure of 8 and they have it. So you can produce any trouble as well. And I think it maybe depends, is it the last eye or is it the better eye that makes now the troubles? And how is the approach of the patient? I always ask the patient now, okay, we have this or that option, and what do you think you come along best? And I wouldn't ask him for a suggestion, but I would ask him what he's more open-minded to which step of the next procedure.
May I also ask, one of those very troubling patients where you have full dose medications and they are already at 10, they're progressing. What would you really do? Because I'm totally hand-tied when I saw one of those.
At first, I would take off all 4 medications.
Right.
And ask him, come in 2 days and in 1 week and look what the pressure is. If the pressure is more or less the same, which can be because they are not taking it or the medications are ineffective, then you have a different approach. If then the pressure is, let's say, 17 instead of 10 without medication, then I would consider surgery as well. Yeah.
Right.
Because then you have the advantage to get rid of the medication too. So it's a quality of life increasing for the patient, probably, and you can discuss it.
Yes, it's a very sensible idea.
What if there is a condition where even after surgery the patient continues to progress? You brought down the pressures to 10, 12, and he's still progressing. I mean, do you look for any sleep studies? Do you look for sleep apnea? Do you look for, how do you manage such patients?
Yes, these are the very frustrating patients. And if I don't have the options to send them to TIN or anybody else, we make the sleep apnea. We have a laboratory in another hospital where we make that. We make the carotid, we make the MRT, and we ask them, do you smoke and migraine and all this stuff? And then we try all these medications, the citicoline maybe or the ginkgo, to do something. But we all know that there are patients. And my father, who was an ophthalmologist, said it 50 years ago. He said, there are 2 types of glaucoma only. The one kind, it's called glaucompion, which is a diminutive of glaucoma, is what you can do with this patient, whatever you want, he will never go blind. And then there are other ones where you can do whatever you want and they go blind. And there are some patients where we must say it is bad luck and you help him and you prepare him.
We also currently have a clinical trial for nicotinamide, so trying potential neuroprotection in those patients, but the trial results is not out yet.
Yeah.
But from the preclinical evidence, there might be some benefit in using neuroprotection, like in nicotinamide.
Okay. Thank you for attending to this morning's symposium. I'd like to thank all the speakers and my co-chair, Cynthia. Thank you very much.
Thank you very much.
Thank you.
Are you fine?
Just on time. Thank you.